for the Isrrt. Welcome to this special Isrrt webinar as we commemorate World Patient Safety Day, which is tomorrow, September 17th. World Patient Safety Day was established by the WHO in an effort to make healthcare safer for everyone. And this year, the theme for World Patient Safety Day is Safe Care for Every Newborn and Every Child, under the slogan, Patient Safety from the Start. And this emphasises the need for stronger measures to protect children from preventable harm in healthcare settings. And I'm really pleased to be joined today by Adele Doyle from the International Association of Forensic Radiographers, or the IAFR. And the IAFR do an incredible amount of work in promoting best practice in forensic radiography. And for children, this is particularly significant in the area of imaging for suspected child abuse. So for today's webinar, Adele will be taking us through recognising and imaging of suspected child abuse. And as always, if you have any questions for Adele, can you please put them into the chat and we will go through them at the end of the presentation. So just to introduce Adele, Adele qualified as a radiographer in Dublin, Ireland in 2005, and she worked at the Tallaght Hospital in Dublin, which incorporated the National Children's Hospital for 9 years before going travelling in Australia for 6 months. And 12 years later, she's still there in Australia. Adele has a master's in CT, a master's in forensic radiography, and a master's in forensic medicine. She has combined her professional interest in CT, forensics, and paediatrics to undertake her PhD. Adele has been a member of the IAFR since 2007 and has been a committee member since 2012. She is a founding member of the Australia and New Zealand branch, and she is the lead author of the IAFR's Best Practice Forensic Imaging Guidelines. Adele is passionate about patient care, and in particular, that radiographers advocate for the more vulnerable members of our society. And this has led her to deliver the IAFR's NAI, or Non-Accidental Injury Workshop for radiographers across Australia and in New Zealand. So welcome to Adele, and I look forward to seeing the presentation.
Thank you for the invitation to present today as part of the ISRT's commitment to support the WHO World Patient Safety Day, with the theme of safe care for every newborn and every child, and a slogan, Patient Safety from the Start. The International Association of Forensic Radiographers has been invited to present on recognising and imaging of suspected child abuse. We are delighted to have the opportunity to work with the ISRT on increasing awareness of forensic radiography amongst their members. Forensic imaging itself can be challenging, but forensic imaging of suspected physical abuse in children can be really difficult. I'll begin with a general introduction to forensic imaging, which is any radiographic imaging that may be used to answer a question of law. Sometimes there is a misperception that forensic imaging only refers to post-mortem imaging. However, this is not the case, and clinically, many of us perform forensic imaging without even realising it. Suspected physical abuse, which some of us may know as non-accidental injury, is an example of forensic imaging of the living that can affect any vulnerable person. Children or those with disabilities who are dependent on someone else to care for them are particularly vulnerable. The World Health Organization report that 6 in 10 children, which is 400 million children, under the age of 5 years regularly suffer from this physical abuse. In 2022, a total of 17% of children abused in the United States of America experienced physical abuse, and it was estimated that approximately 2,000 children died from abuse and neglect in the USA, with 3 per 100,000 boys dying compared to 2 per 100,000 girls. African American children were more than 3 times likely to die than white children, and almost 4 times more likely than Hispanic children. 15% of all victims in the 2022 report were children under the age of 1 year, and 27% of these child abuse victims were no more than 2 years old. In substantiated child abuse cases in the USA in 2022, 76% of children were abused by a parent or legal guardian, while 16% of alleged child abusers were themselves children. Approximately 1 in 14 children in the UK experience physical abuse during their lifetime. In 2022, over 200,000 children were investigated for safeguarding concerns, making a 125% increase since 2010. Child abuse is often hidden, with only a fraction of child victims ever receiving support from health professionals. Therefore, data collected and published is likely to underestimate the prevalence of physical abuse. As radiographers, we are often in a unique position to detect signs and/or symptoms of potential child abuse. Radiographers may find themselves in a unique position whereby they are alone with the patient, or for operational reasons may see the patient in a state of undress, whereby indicators of abuse may be discovered. If physical abuse has occurred, the patient may be dismissive of the injuries present, or they may even refuse to allow staff to treat them. In most situations, a patient undergoing a radiographic examination will wear a hospital gown, but the radiographer or sonographer may witness bruising or torn or bloody underwear, which may indicate sexual abuse if assisting the patient to change into the gown or when helping them into position on the table. Observation of the patient may provide indications of psychological abuse, particularly when they are interacting with their carer, who may demonstrate threatening, belittling, or controlling behavior towards them. Other signs of psychological abuse include the patient rocking, sucking, or mumbling, or the patient may be unreasonably suspicious or afraid of having their X-ray taken, or they may be unreasonably uncommunicative or unresponsive. It is unlikely that a radiographer would witness indicators of financial or material abuse in children. However, the patient may disclose information to the radiographer if they feel they can trust them. Radiographers are quite likely to witness signs that may indicate neglect in the case of a dependent person, but these must be assessed in context with other evidence and pathological causes must be eliminated. Many of these signs will be picked up by healthcare professionals who have regular contact with the person. For example, a radiographer could be alerted if an outpatient attended for X-ray who was wearing inappropriate clothing for the weather, or untreated physical problems such as bed sores, which may be identified if a patient regularly attends for follow-up imaging. Discriminatory abuse is as likely to happen to children as it is to others, and radiographers need to be aware of how they address patients so as to avoid causing insult. Pediatric residents in institutions attend X-ray departments, and it may become evident to the radiographer whilst their patient attends for imaging that they are a victim of institutional abuse. There are a number of general indicators of suspected physical abuse that may come to light during a visit to the radiology department. These include a delay in seeking medical care for an injury or illness. We may see fractures at various stages of healing. A clinical history that doesn't make sense or that doesn't match the injury seen. They must have fallen over, when the patient is not yet walking. Attending the emergency department more often than is usual. Presenting to a new doctor each time may result in it taking longer for healthcare staff to recognize a pattern of frequent visits. Blood test results that don't match the clinical history provided. And the story of what happened provided by the patient doesn't match what their carer said. No history of an injury in the presence of a skull fracture. We must all be aware of the signs and symptoms of suspected physical abuse so that we can recognize it. Having a national or regional information management system will help identify repeat visits, i.e. those frequent flyers, and identify them sooner. All members of staff are encouraged to raise concerns with their manager. A multidisciplinary investigation is vital to ensure that all the pieces of the puzzle are put together and that no piece is left unturned. The last thing we want is for an incorrect allegation to be made. Gathering as much information as possible in relation to the child's medical and social history is vital. It is not often that a radiographer will be alone with a child. However, if others are out of earshot and the child starts to tell you information, It's important that you listen and do not interrupt. Don't ask any questions either. Don't make any promises that you can't keep. Write down word for word what they said to you. Sign it and date it. Make a copy, because this is now evidence. Give one copy to the referring team and scan the other into the patient's file. As healthcare professionals, we have an obligation to report any suspicions we may have to our manager and/or the referring team. If you work in a hospital, you will need to follow their reporting procedures. If you work in a private setting, inform the radiologist as soon as possible. Some of the signs of physical abuse include bruises, fractures, and burns. Accidental bruises are common at places on the body where bone is fairly close to the skin. Bruises can also be found towards the front of the body, as the child will usually fall forwards. Accidental bruises are common on the chin, nose, forehead, elbow, knees, and shins. An accident-prone child can have frequent bruises in these areas. Such bruises will be diffuse, with no definite edges. Any bruising on a child before the age of mobility must be treated with concern. Bruises caused by physical abuse are more likely to occur on soft tissues. For example, cheek, buttocks, lower back, thighs, calves, neck, genitalia, and mouth. Marks from slapping or grabbing may form a distinctive pattern. Slap marks might occur on buttocks or cheeks, and the outlining of fingers may be seen on any part of the body. Bruises caused by direct blows with a fist have no definite pattern, but may occur in parts of the body that do not usually receive injuries by accident. A punch over the eye or ear would be of concern. Black eyes cannot be caused by a fall onto a flat surface. 2 black eyes require 2 injuries and must always be suspect. Other distinctive patterns of bruising may be left by the use of straps, belts, sticks, and feet. The outline of the object may be left on the child in a bruise on areas such as the back or thighs, which are areas often covered by clothing. Bruises may be associated with shaking, which can cause serious hidden bleeding and bruising inside the skull. Any bruising around the neck is suspicious, since it is very unlikely to have been accidentally acquired. Other injuries may feature, such as a ruptured eardrum or fractured skull. Mouth injury may be a cause of concern, for example a torn mouth or frenulum from forced bottle feeding. Children regularly have accidents that result in fractures. However, children's bones are more flexible than those of adults, and the children themselves are lighter, so a fracture, particularly of the skull, usually signifies that considerable force has been applied. A fracture of any sort should be regarded as suspicious in a child under 8 months of age. A fracture of the skull must be regarded as particularly suspicious in a child under 3 years. Either case requires careful investigation as to the circumstances in which the fracture occurred. Swelling in the head or drowsiness may also indicate injury. Children who have accidental burns usually have a hot liquid splashed on them by spilling, or have come into contact with a hot object. The history the parents give is usually in keeping with the pattern of injury observed. However, repeated episodes may suggest inadequate care and attention to safety within the house. Children who have received non-accidental or inflicted burns may exhibit a pattern that is not adequately explained by parents. The child may have been immersed in a hot liquid. The burn may show a definite line, unlike the type seen in accidental splashing. The child may also have been held against a hot object, like a radiator or a ring of a cooker, leaving distinctive marks. Cigarette burns may result in multiple small lesions in places on the skin that would not generally be exposed to danger. There may be other skin conditions that can cause similar patterns, and expert pediatric advice should be sought. Shaking is a frequent cause of brain damage in very young children. Imaging can play a vital role in the identification of these bony injuries. Fractures that are commonly associated with suspected physical abuse include bucket handle fractures of the metaphyses, fractures of the ribs, particularly posteriorly from squeezing. CT is used to detect subdural hemorrhages caused by the rapid acceleration, deceleration, rupturing the subdural blood vessels during violent shaking. Rib fractures are more common than long bone fractures and are highly suspicious for SPA in the absence of metabolic bone disease. Metaphyseal fractures are also referred to as bucket handle or corner fractures. The most common long bone fracture is the distal femur or proximal humerus, and these are found in 40 to 50% of abused children under the age of 18 months. The cooperation of parents or carers should be sought by the multidisciplinary team for any examinations or assessments considered necessary. The medical or specialist practitioner who carries out an examination or assessment as part of the investigation must provide a written report of their findings and must be made aware that they may be required to give evidence in court. Cases of SPA are admitted to the ward for observation and further investigations. These may include ophthalmology for retinal hemorrhages or blood tests to outrule metabolic disease. Requests for skeletal surveys of such children are discussed by the referring team with the consultant pediatric radiologist. This imaging will be performed during normal working hours by 2 radiographers. We will now review some of the guidelines available for radiologists and radiographers that can inform our imaging approach. The American College of Radiologists published their resources in 2016. This is a true multidisciplinary document from the UK, a joint publication in 2018 written by the Royal College of Radiologists and the Society of Radiographers, and endorsed by the Royal College of Paediatrics and Child Health. These guidelines, published in 2022 by the Royal Australian and New Zealand College of Radiologists, provide limited information for radiographers, particularly in relation to medical legal aspects of image acquisition and record keeping. There is an international group currently undertaking a Delphi study which consists of 6 subgroups and will result in the publication of a consensus guideline. The group is multidisciplinary and includes radiographers, radiologists and paediatricians, amongst others. One group is considering the skeletal imaging of index children and contact children with suspected physical abuse, whilst there are 5 other subgroups working on the detailed imaging required in indications, visceral, neuroradiological, post-mortem, and imaging adaptations required for low and lower middle income countries respectively. This will be a very valuable resource when published, as it will outline the imaging pathways from modalities including X-ray, CT, MRI, and nuclear medicine. Hopefully we will see it next year. These IAFR guidelines were reviewed in 2020 and revised in order to make them more applicable for our international members. They provide generic medico-legal principles that can be applied to all forensic imaging cases, including SPA. Ireland has been well ahead of other countries in providing advice to radiographers. The Irish Institute of Radiography and Radiation Therapy published their first set of forensic imaging guidelines in 2003, with the most recent edition being published in 2023. These guidelines are a professional standard against which local policies, procedures and practice in Ireland will be measured. The IAFR are grateful to the IRT for allowing them to reproduce their witness document in our forensic imaging guidelines. The Society of Radiographers in the UK led the way in providing guidance to radiographers in 1998 when they published their first forensic radiography guidelines. In February of last year, they published a set of guidelines in collaboration with the UK branch of the IAFR. They provide more detailed recommendations around the use of digital imaging and have moved away from keeping master and working copies, as long as there is a secure storage or PACS used. Reviewing the international guidelines provided a number of key areas where the radiographer plays a vital role in the investigation of SPA. The emotional impact that can have on radiographers involved needs to be acknowledged by management, and appropriate support mechanisms must be in place. Jessica Eaton, a radiographer at Great Ormond Street Hospital in London, has published a narrative in JMIRS on the perspective of the radiographer. It is very insightful to read, particularly for managers. Each jurisdiction is responsible for defining a forensic radiographer. However, They must be appropriately educated and trained to undertake the role and be able to provide evidence of CPD relating to forensic knowledge, skills and competence. They must be aware of all legislation and guidelines under which they work, as this is the standard against which they will be measured in a court of law, and they must be able to justify any deviation from best practice. It's extremely important that radiographers working in situations where SPA is suspected understand their role and responsibilities in this area, and in the provision of high-quality imaging. Imaging in SPA and forensic radiography techniques do not form part of the threshold standards required for registration as a diagnostic radiographer. It is recognized that these elements require post-registration and postgraduate level training and development. There is no doubt that all suspected physical abuse cases are forensic in nature. They will not change the clinical management of patients, and therefore are non-medical referrals and are not clinically urgent. They should not be performed out of hours without the appropriately qualified staff on site, including radiologists who can review the images as they are taken and request additional projections when needed. Skeletal surveys should only be requested by a consultant paediatrician when the patient has been seen by the child protection team. The request should be discussed with the consultant radiologist. SPA imaging should always be performed by a minimum of 2 radiographers with an appropriate witness present. Acute injuries should be imaged promptly to facilitate clinical management. However, forensic imaging should be performed with the radiologist present who can review the images and advise if further projections are required. It's an important part of the process that the child is admitted for observation for a period of time, during which their interactions with other family members can be monitored closely. As with clinical cases, patient confidentiality must be respected. Details of SPA cases must not be discussed within the radiology department, except by staff members directly involved in the case. Often these cases can attract attention in the tea room, so it must be acknowledged that discussion is not appropriate. Looking after our own mental health and that of our colleagues is really important in a forensic imaging team. Being aware of the signs and symptoms of post-traumatic stress disorder in ourselves and our colleagues is paramount. The IAFR have a dedicated welfare officer to provide advice and support to our members, and this is a confidential service. All employers should offer access to counselling to staff via their Employee Assistance Programme. The IAFR recommends that student radiographers should not participate in forensic imaging examinations because forensic radiography is not a first post competency. Forensic radiography or imaging examinations are undertaken for medical legal purposes, and it is therefore essential to accurately document the examination, which would include a record of the student having been present. Therefore, the student may be asked by a coroner or medical examiner or court to act as a witness to the examination itself. Student radiographers who find themselves in this position will be vulnerable due to their lack of practical and professional experience. The effects of being involved in such an incident may adversely affect their studies. In the event that a student chooses to observe a forensic imaging examination, appropriate support must always be available from the imaging department, and the university must be notified that the student has observed a forensic radiography or imaging examination. Consequently, the university is in a position to offer appropriate counselling services to the student. It is recommended by the IAFR that student radiographers are given the opportunity to develop a theoretical awareness of forensic radiography practice during their final year of study, to enable them to make an informed decision about their involvement in forensic radiography when commencing their professional career. Graduate radiographers should have the opportunity to be involved in forensic imaging practice upon qualifying. This should be undertaken following additional education and training in accordance with the IAFR forensic imaging guidelines, and staff should be appropriately mentored throughout the process. Forensic radiography requires postgraduate education and then ongoing evidence of CPD relating to forensics. There are a number of online forensic imaging courses which include pediatric SPA. Forensic radiography is a specialist area that should only be undertaken on a voluntary basis. It's also important that radiographers can withdraw from being involved in forensic services because there may be personal circumstances that prevent them from being in a strong mental position at that point in time. This decision must always be respected, and they should always be welcome to return to the forensic imaging team. All aspects of forensic imaging should be documented by those involved. Imaging of SPA is a medico-legal examination, not a medical examination, so the risk-benefit analysis is different. European legislation recognises that written consent is preferable, as a higher level of information is expected to be provided. Consent must be informed, so it is often gained by the referring paediatric team, as they hold the most knowledge regarding the clinical indicators and the social history of the patient. However, the radiology team are best placed to answer questions relating to radiation risk. We must always confirm that the primary caregivers, such as the parents, are happy to proceed before we start any imaging. If the primary caregivers refuse to consent to the child undergoing imaging or withdraw their consent, the child may be made a ward of court, where decisions are made by court representatives in their best interests. Daly states that failure to obtain valid consent amounts to trespass against the person under civil law or to battery in criminal law. Whilst it's relatively rare in the UK, Ireland or Australia to file such charges against a healthcare professional, and such charges are unlikely to succeed, radiographers must be aware of the legal requirement and their ethical duty to seek consent prior to undertaking any examination on a patient which involves physical palpation of bony landmarks. We must remember that the radiographic images that we produce form part of the evidence documents. There must always be two radiographers present who can confirm that the images produced in court are those taken at the time of imaging, and that they have not been altered in any way by image processing. Non-radiographers are unlikely to have the depth of knowledge and understanding to be accepted as a credible witness of fact by the court. To be admissible in court, the evidence must be properly authenticated and continuity of evidence must be demonstrated. The following issues should be addressed: the date and the time, the names of both radiographers, anatomical markers present on the image at the time of exposure, maintaining the chain of evidence, digital imaging, and record keeping. To support their members, the Irish Institute of Radiography and Radiation Therapy have produced their own witness statement template in Appendix B for radiographers to complete as their contemporaneous notes when undertaking any forensic imaging. This is an example of a witness document that should be completed by the appropriate witness during the imaging examination. The IAFR also have a contemporaneous document that we recommend is adapted based on the local SPA imaging protocol and is used during imaging and then scanned into the patient's file. A radiographer can only refer to their contemporaneous notes when giving evidence in court. It should be noted that a well-written report by the radiographer may prevent an appearance in court. Documentation and record keeping is of critical importance in this area of work. Unless accurate records are maintained, the ability to adequately protect vulnerable children may be severely curtailed. It is essential that healthcare professionals keep contemporaneous records of all reported concerns in a safe place. The Society of Radiographers recommends that where a forensic radiographer keeps their own written documentation, this will be held confidentially as a personal record of the examination. Records should be factual, accurate, and legible. They should be dated and signed after each entry, and they should be recorded on the day that the action took place, or at the latest the following day. They should also include details of contacts, consultations, and any actions taken. It is best practice for the anatomical side marker to be included within the irradiated field at the time of exposure. Where the radiographer has followed the proper process and the image quality is satisfactory, except for the visibility of radiographic markers, repeat imaging would not normally be necessary or appropriate, but this should be confirmed with the radiologist, as there must be no opportunity for an element of doubt to be introduced by the defence. The appropriate witness should ideally be a radiographer who understands the imaging process. The child in an SPA case should always be accompanied by a nurse or a member of the referring team who remains in the X-ray room with the child whilst the radiographer and appropriate witness process the images. Detailed documentation of the entire radiographic examination must be undertaken. The role of the appropriate witness is to ensure that the images produced are admissible in law as evidence, and to reduce the risk that any challenge to the validity of that evidence will be successful, so they must be present during the entire imaging examination. They may be required to validate in court that any injuries present were not caused or exacerbated in any way by the radiographer during the acquisition of the images. Ideally, there should be a pro forma available for the appropriate witness to document all activities of the radiographer. How many of us here today, if cross-examined in court, could confidently defend the image acquisition and processing chain in layman's terms without introducing an element of doubt? The Irish Institute of Radiography and Radiation Therapy have a very specific section on digital imaging, including how this would work with the national PACS system in Ireland. They have described having a master copy and a working copy. The Society of Radiographers in the UK updated their guidance on this in 2024, saying that digital data must be stored with adequate security against unauthorised and unrecorded access with appropriate traceability. That's a question for your local PACS teams. Can access be restricted to staff involved in the case only? I'm currently enrolled in a PhD in Monash University in Melbourne, where I'm researching if a low-dose CT skeletal survey could replace about 33 projections in the standard skeletal survey X-ray series. It's really important that as new technologies develop, an evidence base is generated before implementing a new clinical practice. This is even more important in forensic imaging, as it will be tested in a court of law. We can't afford to produce imaging that results in fractures being missed, as this may be fatal for the child. Current published literature has been thoroughly searched and reviewed by multiple authors, all confirming the role that CT plays in detecting head and rib injuries, but there was no peer-reviewed evidence regarding the use of CT to detect metaphyseal fractures. My PhD supervisors and I have published a phantom study which proposed a radiation dose that is representative of the dose delivered for a skeletal survey X-ray series from 5 radiology departments in Melbourne, using their equipment and protocols to X-ray a 5-year-old anthropomorphic bone fracture phantom, weighing 20 kilos. The estimation of the radiation doses had to be recalculated by scaling the doses down from a 5-year-old to a 2-year-old. The median effective dose for the RCR skeletal survey X-ray series was 0.09 millisieverts, which results in a very low additional risk of radiation-induced cancer, 1 in 40,000. The additional radiation-induced death, 1 in 90,000, is equivalent to the risk of dying from being struck by lightning. This information can help radiographers put radiation dose associated with the skeletal survey X-ray series into perspective for the carers as part of the consent process. The original idea was that the results of my empirical studies would inform our post-mortem CT study, which was granted ethical approval by VIFM, which is the Victorian Institute of Forensic Medicine, but the data collection has been put on hold due to operational reasons. In the meantime, recent publications have provided evidence-based research that could be used to support any proposed change in clinical practice. Retrospective ethical approval was granted for this first study by Lawson et al., published in 2020, that involved 10 living patients who only had CT and no radiographic skeletal survey. It was noted that for one of the 2 children who died, the ante-mortem CT skeletal survey failed to demonstrate 5 of 7 metaphyseal fractures shown on the post-mortem CT skeletal survey. These 5 metaphyseal fractures, however, were visible on the ante-mortem CT skeletal survey, with improved 3D reconstruction using a sharper reconstructive kernel, axial to the metaphysis. This was a very instructive case, highlighting the need for careful reconstruction of the metaphyses, although a further study in this area is required according to the authors. Shelmerdine et al. Published a 10-year retrospective review of 10 cases who had post-mortem radiographic skeletal survey and post-mortem CT compared to histopathology as the reference standard. They concluded that radiography remains preferable to CT, with X-rays of the limbs required to exclude those corner metaphyseal fractures. And most recently, the findings of this post-mortem study by Lawson et al. Are reported to suggest that ultra-low and low-dose CT may outperform the initial radiographic skeletal surveys in detecting fractures. The novel CT protocols used in their post-mortem study detected 90% of fractures identified on the consensus list, so further research in live clinical settings is needed to replicate these results according to the authors. When involved in forensic cases, we must ensure that we keep an open mind. Please put yourself in the shoes of the parents or the carers and imagine what it will be like to A. Have your child investigated for SPA, and B. Be accused of causing the inflicted non-accidental injuries to your child. In most countries, the suspect is innocent until proven guilty in a court of law. Professor Naomi Shiner is a radiography lecturer in the UK. In her article, she shares her experience as a mother of Nina who has Down syndrome. She says, "I cannot write about our experiences of visiting imaging departments without sharing the worst experience of my life. I noticed bruising behind Nina's ear on the side of her head. As a reporting radiographer, I knew this was not normal, and I raised safeguarding concerns to the doctor, triggering the SPA policy. In the beginning, I felt okay. Concern was shared by all, and I felt unified in the process. I was scared for the health of my daughter. What had happened? I knew I had done nothing to my daughter. I was innocent. However, the inability to be alone with my daughter meant I felt under suspicion. I felt ashamed even visiting the X-ray department for the skeletal survey. I had to sign a contract stating my parents would observe me when I was with my little girl. In Nina's case, all imaging was normal, including the second skeletal survey. Naomi was told that they felt the bruising was due to Nina's hypotonia and repeated pressure in that region from the feeding technique. The case was closed for the hospital and social services. But for Naomi, it's something that she continues to live with. Support for the parents in these investigations is minimal to none. I strongly encourage you to read Naomi's article. It is open and honest, and a stark reminder of how it feels to be on the other side. Jessica Eaton's letter to the JMIRS editor summarizes perfectly that many radiology departments persist in outdated views that limit family involvement, routinely separating children from their primary caregivers during skeletal surveys. As radiographers, we must reflect on these decisions and work to prevent harmful practices. Whenever safely possible, involving family members not only eases the experience of the child, but also provides us with crucial insights to deliver the most compassionate, personalized care. It's crucial to recognize the vital role of caregivers in supporting their children during medical imaging procedures, and a better approach would be to accommodate their involvement whenever feasible. I urge you to reflect on your local approach regarding the inclusion or exclusion of the parents or carers during pediatric imaging examinations. As healthcare professionals, we should always advocate for our patients, especially those who can't speak for themselves. They're particularly vulnerable in our society. We have a responsibility to speak up on their behalf if we have any suspicions relating to their welfare. I agree with Naomi and Jess. We should be advocating to have the parents or carers in the room during imaging, as it may bring comfort to the child, rather than being surrounded by strangers in a new environment which is alien to them. If you would like to learn more about the International Association of Forensic Radiographers, please visit our website www.ifr.org.uk or www.forensicradiography.com. The IAF4 is open to anyone who has an interest in forensic imaging. And don't forget that this includes medical legal imaging examinations on the living, such as SPA. The IAF4 endeavours to provide education and practical training where possible in relation to forensic radiography. In June this year, the UK branch of the IAF4 presented Skeletal Survey 101, helping radiographers to understand the SPA process as a whole. It's available to view at a cost of $15 or it's free for IAF4 members. You can purchase virtual registration for $170 until the 30th of November to watch the presentations recorded recently at the joint IAF4 SORSA conference. There were 2 entire sessions dedicated to suspected physical abuse, with international speakers as well as presenters from South Africa. These are available to be viewed until the 15th of December. The IAF4 offers an e-learning course on SPA, which costs $75 via our e-learning website, and there's also a supporting practical workshop. These are the main references for radiographers that I've used today. A full list of references is available on request by emailing me chair@iaf4.org.uk. I hope that you have learned something today to help in recognising and imaging of suspected child abuse, so that as radiographers we can ensure safe care for every newborn and every child. I would like to thank Isrrt for the opportunity to increase awareness on this aspect of forensic radiography amongst our colleagues internationally. Most importantly, thank you for listening, and I'm happy to answer any questions.
Thank you, Adele, for that wonderful presentation on an incredibly important topic regarding suspected child abuse. Adele, I would like to invite you to turn your camera on. And for those who have been watching, thank you very much for your attendance. If you do have any questions, please feel free to pop them in the chat. Adele, I'm going to start by just asking some questions that I've come up with myself. Thank you very much for your time and putting this presentation together. And then I think it was incredibly valuable to many of the radiographers out there. My first question was one that was actually answered right at the very end of the presentation regarding parents coming into the room in terms of the advocacy. I have noted though that certainly in the experiences that I've had in the past, that sometimes parents, or sometimes there can be a big difference between one radiographer and another within an institution about whether they would prefer a parent to come into the room or whether they would prefer the parent to stay out of the room, with varying reasons, such as, for example, parents perhaps being a little bit overprotective and being a bit of a hindrance to the skeletal survey examination, which can then, of course, mean that that examination takes longer, even though it can be quite distressing for the child as well. What would you kind of suggest for institutions in terms of kind of enacting their own policy around this?
So this is one of the topics that we spend a lot of time discussing in the practical workshop. If we go back and read the 2 articles that I referred to by Jess and Naomi, we have to understand why we are performing the imaging that we're performing. This isn't about us as radiographers. This is about the patient, which is the child. It's not always the child in terms of the index child, which means the child that has the injuries. Sometimes it's contact children, so it can be siblings. So we have to bear that in mind as well. We are one piece in a very big puzzle. And when we talk about having the nurse in the room, there should be an observation process occurring. And part of that is an independent person watching the interaction between the child and the parents, and watching if there's a difference in the interaction with one or the other, because that all helps feed into the evidence that the referring team or the investigating team are collecting to try and work out if this is a case of physical abuse or not. So we have to understand the role that we're playing in a much bigger picture. Again, one of the things that we discuss is if there is a particular parent present in the room that's increasing the distress for the child, obviously we can ask them to leave. But in most cases, the parents are a source of comfort to the child because they're familiar with them. And I think no matter what, we do find that even parents or caregivers who may turn out in the end to be the abuser is still a source of comfort to the child because it's an innate quality that we have. It's not something that the child chooses. So I think it goes back to understanding why we're performing this imaging examination and the role that we play in the bigger picture.
Yeah, yeah. The person that you described as the observer, I guess, of the interactions, I guess, that's happening in that, is that someone that needs to be trained to be able to do that?
So they're usually part of the investigation team. So there's a child protection team in some countries. It may be a pediatric team in another country. It depends on the institution that you're working in. And obviously that varies hugely across the world. But anybody who's involved in the investigation should be trained. So it could be a social worker, it could be a nurse, it could be the pediatrician. And in the description of a pediatrician, it could be the registrar, it could be the consultant. It all depends on who's available locally to play that role. But it's important that we have that person there so that if something happens in our x-ray room, there's an external witness to what happened. It's not just us reporting it.
Yeah, and a question I think came through from Tatenda as well. Should that particular person be helping with positioning, or should they be merely purely observing?
It depends on who they are and what your local policy and local training is. If it's somebody that is available to us and is willing to participate, that's up to them. It could be somebody that causes additional distress to the child because they may associate them as giving them medication or whatever's happened up on the ward. So it's like anyone, it's about judging what happens in that individual situation at that point in time and working out what works best for the child so that we can get the best images that we can in the shortest possible time.
Yeah, yeah. Such a complex situation. I think that whole skeletal survey thing as well. Another question's come through from Shad Mohammed, which is what strategies can be applied to ensure the psychological safety of the child during the imaging procedure?
I think that applies to all of our imaging. We are aware that it can be distressing for the child. We don't know what previous experiences they've had in a radiology department. And that's one of the reasons why we aim to ensure that our imaging is done in a safe manner, and that includes physical and psychological safety, which is why if somebody in the room is causing distress to the child, we will ask them to leave and we will try and find a replacement person. We all know that grandparents can be a great substitute for parents sometimes, and it's using the people that the child is most comfortable with as long as we have a legal guardian present. So it's another aspect of safety, and it's not just physical safety, it is every type of safety because we don't want to traumatize the child. They should be coming back for follow-up imaging. If they've got an acute injury, which is what caused their presentation in the first place and raised the red flags, they're going to come back for follow-up imaging at the fracture clinic. And we don't want to cause distress every time they come back to an x-ray department. And that could be for the rest of their lives into adulthood because some of this can be subconscious. So it all plays a really important role, which is why we need our radiographers to be trained.
Yeah. And I was going to ask a question about the training actually side of things in terms of what, like you did mention a little bit about some of the training that's available in that. What level of training would you recommend for radiographers who are, I guess, regularly kind of being involved in these types of things? You do get some radiographers, and I've got another question about that later, but you do get some radiographers that obviously only do this maybe once or twice a year, but you do get some radiographers that are obviously involved in these cases every week. So what kind of level of training are we talking about for those people?
I think the first thing that we need is people who are actually trained to work with children, because primarily that's what we're doing. So there should be two radiographers present. Both should have pediatric training, and they should understand the different adaptations and modifications that we need to make based on the age of the child and their developmental age, not just their chronological. Personally, I think that's the most important foundation. But at least one of those two radiographers training. And that means going and, in most countries, going and finding education that's not routinely available in our undergraduate degrees. There may be a basic introduction, but a lot of it is CPD, and it's finding out what you don't know, which is a very hard thing to do because obviously you don't know what you don't know. So interacting with the pediatric teams in your own hospital is a really good starting point because there's often training for nurses that we can tap into that may not be specific for radiographers, but it will start to give us an understanding of the bigger process that we're involved in. So there's lots of opportunities out there, but at the end of the day, we're part of a multidisciplinary team that are trying to find out what's happening for this child and to keep them safe ultimately.
Yeah, absolutely. An absolute flood of questions are coming in now. One from Elizabeth from Africa, who has asked, why can't student radiographers assist or stand at least witness, even when they could be training as forensic radiographers themselves?
So students don't train as forensic radiographers. It is not a graduate competency anywhere in the world that we're aware of. The reason that we recommend that students aren't present is because anybody who's in that room can be called to court as a witness of fact. Now, a witness of fact is somebody who is basically questioned by the court to corroborate that what we say happened actually did happen. If we think about the fact that we've got a student in the room, they are not qualified. They are at a higher risk in most cases of the defense barrister trying to find holes in what they say and trying to basically get their defendant off the hook. So I don't think that's fair on any student. I don't think it's the start to any of our careers that we would want. And we have a duty of care to all of the students that come into our department to make sure that if they are involved in observing these cases, that they know what they're involved in and that there is support from the university, because we don't know what it may trigger for them either at the time or later on in their careers, because we don't know what's happening in their lives at home. And I think that's something that we have to bear in mind with students. We don't know them as well as we may know our own colleagues.
Mhm. Yeah, I think you're right. And, at least if they are going to witness, that adequate preparation, I think, for them to understand fully about what they are actually about to witness and what it's actually what the experience could actually be like. And then giving that student then an opportunity to then decide whether they want to still be involved after being informed about that as well, I think, too. Another question is regarding other types of imaging, and that was whether MRI is actually now used as forensic imaging.
So all modalities can be used because the definition of forensic imaging is any imaging that's used to answer a question of law. Nuclear medicine bone scans are used in the investigation of suspected physical abuse. So literally all of our modalities, whatever tools we have in our toolkit, we will use to try and answer that question.
Yeah. I was going to ask about that because I know that there is a big difference, I think, between one institution and another in terms of the type of imaging that they use, whether they use a follow-up skeletal survey, whether they use a nuclear medicine bone scan, whether they may use CT or MRI or something like that. Is there any specific international guideline as to what really should be done? And even within, say, a skeletal survey, there's, you mentioned in your presentation 33 different views, but I know that most places don't do 33 different views. And we're talking about things like cone views of joint spaces. We're talking about orthogonal views in some cases, whereas I know institutions that don't do the orthogonal views and that. What are the international guidelines actually saying?
So at the moment, there aren't international guidelines. Each professional body, so the American College of Radiologists, the Royal College of Radiologists in the UK, and Randstad in Australia and New Zealand, and Germany have their own protocols as well, and they actually recommend 17 projections. So at the moment, there is no agreement as to what should be done, but there is a consensus project going on at the moment, which I did allude to, and we had a presentation in Cape Town last week about the progress of that. And it includes the different modalities. It includes whether it's the index child or whether it's the contact child, because do they need the same level of imaging, depending on how high the suspicion is. So as you said earlier, this is hugely complex, and it really is on an individual basis. But you need experts involved in the field. So we need our radiologists talking to the pediatricians. We need them to all understand what evidence is already there. How high is the suspicion? And then, as the radiology team of radiographers and radiologists and nuclear medicine technologists, what can we do to contribute and to help narrow down the diagnosis or the exclusion of physical abuse? Because sometimes our imaging will help basically say this isn't physical abuse. And then in conjunction with blood tests, it may be a metabolic bone disorder. And we have to keep that in the back of our mind as well.
So we think it's probably too complex, I guess, then to have a position statement around it. And
they're hoping to publish next year. So it's going to be really interesting to see what comes out of that. I think they have 136 participants. I'm trying to remember what Imacum said last week, but they've got a wide range of countries involved. And they've also got a working group who are looking at low and middle income countries, because obviously the resources that we have available across the world vary as well. So that all has to be taken into consideration. Yes, we have a gold standard, but it has to be realistic.
Absolutely, absolutely. Another question's come through from Stuart Whitley. Thank you very much. Hello, Stuart, who's over in the UK. Stuart's asked about the police involvement. So, are they allowed to be present in the room?
I don't think I've ever come across a case where we've had the police in the room for suspected physical abuse, because it tends to be investigated by the medical team. And then once the diagnosis of physical abuse has occurred, it will then be reported to the police, and then they become involved. So usually by the time the confirmation has occurred, imaging tends to be out of the picture. Perhaps other people have had different experiences in other countries, but that's based on my personal experience in two different countries.
Yeah. I want to kind of just go back to one question that I asked a while back, and that was about the training, the level of training that people should have. And that because one of the things that I mentioned was that there are some groups of people, obviously, that are only doing one or two. And I'm thinking about, like, if I'm thinking about Australia, for example, most of these types of examinations tend to be done in the dedicated pediatric centres. But I know that there are other centres out there that do see pediatrics that do get asked to do these skeletal survey examinations. And I've actually noted even that there's people present in this particular webinar today who are actually from these particular institutions as well. What would you recommend to them in terms of trying to get that education for them to be able to assist them in order to maximise the benefit of these examinations for them?
So I think it's like any radiography, and it's about our scope of practice. If there's something that we haven't done for a while or we don't do routinely, the first question that will be asked in a court of law, which is where this will potentially end up, is how often do you do these? And if you don't do very often, how do you maintain your CPD and your currency of practice? So the only way that those individuals can do that is by attending webinars like this, so that they get the certificate of attendance to show that they're trying to keep up with any changes. It's by attending the workshops, the practical workshops that we run. It's by undertaking the online learning that's available to them. But I think my bigger question is, how isolated do they feel in performing that imaging? Where do they fit in to the multidisciplinary team? If they've got a concern or they've got a question, how do they contact the referrer? So I think all of that needs to be considered. It's not just as simple as providing training and thinking that we can do it. It's about understanding where we fit into the bigger picture, and do we have the support that we need to do our job? So again, it's not an easy answer. It's not that we can go and do a course and come out and say, I can do this from now on. Even by attending a course, you have to maintain your recency of practice. And I think that's the biggest challenge if they're not being done regularly or frequently.
Yeah, and I think the unfortunate reality is that they're probably also not necessarily in a position to say, well, no, we're not going to do this because we don't have the expertise in this. This patient actually should be getting sent to a centre that can actually do it, because I think that then creates more problems, I think, in other situations down the track as well. So, like I said, it's incredibly complex.
The other thing to consider in that scenario is what radiologist is going to report on those images.
Yeah.
Because we need to have a pediatric radiologist who knows what they're looking for and can come back to us and say, your AP elbow looks a bit dodgy. I know we've got a lateral, but can you do an oblique for me before you let the
Hmm.
child go? If you don't have that radiology support, and whether that's teleradiology now or whether it's somebody on site, again, as radiographers, we're being put into a really difficult position. So I think it's a conversation to have with the radiologist and knowing who is the go-to person in your institution and how do you contact them if a case does turn up, because they're the ones that should be talking to the referrer and understanding why the child has turned up to us and why they're not under a team in a hospital where they're part of a multidisciplinary investigation.
Yeah. And I just want to finish with one more question, and that question is basically around the number of radiographers. I know that you mentioned that two radiographers is the recommended kind of standard, I guess, and certainly in the experiences that I've had, we've had three radiographers in there, where generally it tends to be two radiographers in the room with the patient, wearing lead, positioning the patient, getting them all and collimating and that, so on and so forth. Whereas they've had one radiographer actually out at the console who has actually been setting the exposures and actually taking the radiographs. Do you think that two is enough? Do you think that perhaps there should be a recommendation for more than two for each examination?
Two is the minimum, and the reason that we recommend it is based on the fact that we encourage the parents or carers to be in the room and holding the children for the examination. So therefore, you just need one radiographer to position and guide the carers or the holders, and the second radiographer is behind the console, setting the exposure factors and making the contemporaneous notes. So
Mhm.
it basically depends on your local policy around holding and immobilization.
Mm, mm. Yeah. Again, another complex thing with it. So, Adele, thank you very much for taking the time to put your presentation together, to deliver that presentation, and for logging on today, all the way from Scotland. It's been a pleasure to talk to you about it. Obviously, a topic that you're incredibly passionate about, as of course am I, and many of the people who have logged in today. And that, so thank you very much for taking that time. Thank you to everyone else as well for joining us for this webinar, and we look forward to seeing you at the October webinar coming up shortly. Thank you.